Welcome to the Deep Dive. We're here to boil down complex clinical knowledge, give you those high-value insights you can use.
That's the plan.
Today, we're tackling something huge in men's health. Those bothersome micturition complaints, or as they're widely known, LUTS, lower urinary tract symptoms.
Yeah, really common if you're a man over 40 or, you care about someone who is. This is pretty essential stuff.
Absolutely.
And, LUTS accounts for a massive number of primary care visits. The latest clinical standards, they reveal a really crucial shift in thinking.
Okay.
So if there's one thing you take away right at the start, it's this. That old belief, the one we've heard for decades, that LUTS equals prostate enlargement.
BPH?
Right. For most men, that's actually medically outdated. It's often incorrect.
Okay, wow. That's the big takeaway then. That's what we need to unpack. So we're talking about this collection of symptoms, LUTS. Things like difficulty starting urination,
Hesitancy, yeah. And a weak stream or feeling like you haven't quite finished emptying.
That incomplete feeling, right? And the annoying post-micturition dribble.
That too. Plus urgency, needing to go right now, and frequency going often, including, importantly, waking up at night. Nocturia.
Nocturia,
Yeah.
Gets mentioned a lot.
And it's really prevalent. Moderate to severe LUTS affects something like 20 to 25% of men over 40.
A quarter of men, roughly.
And it just goes up with age. But the key point from the sources is that in primary care, most of these cases, they're classified as aspecific Micturition complaints.
Aspecific, meaning
the direct cause is often unknown. It's usually multifactorial, generally benign, and crucially not just down to the prostate being enlarged.
Okay, that sets us up perfectly for the first big point. This BPH misconception, benign prostatic hyperplasia. Society, maybe even doctors historically, we sort of jump to that conclusion, don't we?
We absolutely do. It's been the default for a long time.
So why are the latest guidelines pushing back so hard against that? What's changed?
Well, fundamentally, the physiology is just way more complex than a simple pipe blockage. If LUTS was always just BPH, you'd expect symptoms to line up perfectly with prostate size, right?
Makes sense. Bigger prostate, worse symptoms.
But they just don't. Prostate enlargement, BPH, it typically starts in the peripheral zone of the prostate.
Okay, the outer part.
Exactly, which means it often compresses the urethra quite late in the process, if it even does significantly. We see plenty of men with really large prostates who have barely any symptoms.
And the opposite, too.
And the opposite, absolutely. Men with quite severe LUTS, but their prostate is only slightly enlarged.
So if the prostate gets blamed so much in, general conversation, why has it taken clinical guidelines a while to really move past this single organ idea? Is it just simpler to point to one thing?
It definitely is simpler. And, historically, looking at the prostate, imaging it, that was one of the few things we could objectively measure easily.
Right, you could see it on an ultrasound.
But as the research got better, we realized, hang on, this is more of a systemic issue. It's about the whole lower urinary tract functioning, or maybe not functioning, as a unit.
So LUTS symptoms are rarely just one thing going wrong.
Very rarely. They are truly multifactorial. It's a network effect.
Okay, so if we're looking beyond just the prostate gland, what are some of these other factors? Because the list includes things that sound kind of disconnected from the bladder itself.
This is where it gets really interesting, actually. It's not just plumbing. It's about control systems, too. You've got issues potentially with the bladder wall itself. Maybe it's lost elasticity, can't stretch properly.
It stretches too much.
Or too much, yeah, becomes overstretched, floppy, and then doesn't contract effectively to empty. And then, this is really key, neurogenic regulation.
Nerves.
The signaling between the bladder, the spinal cord, the brain. If that communication pathway is off, you get problems.
Okay. So that connection, the neurogenic part, that explains why things like diabetes or high blood pressure are on that list of factors, right? Because they could affect nerve health, blood flow.
Precisely. Systemic issues like vascular problems, they impact nerves and muscle tone all over the body. That includes the pelvic floor muscles, which are crucial for bladder control.
And medications, too. You mentioned those.
Oh, definitely. Really common ones. Some antipsychotics, certain antihistamines, even some types of diuretics can make LUTS worse.
Wow.
And then lifestyle plays a role. Being overweight, high intakes of coffee, alcohol. They all feed into this complex picture. It's like an orchestra where the prostate might just be playing a small part, sometimes not even the main melody.
So it sounds like diagnosis has to be super personalized if you're looking at everything from blood pressure meds to coffee habits. But before we get into how clinicians assess this, what are the definite red flags? The things that make you stop saying aspecific and send someone to a specialist right away.
Yeah, we always have to screen for that small group with serious underlying causes. The big warning signs are painless macroscopic hematuria that's visible blood in the urine, even just once.
Okay, any visible blood, see someone.
Absolutely. Also, symptoms that come on really fast, severe symptoms, especially with a fever or feeling generally unwell,
Like an infection, maybe.
could be, or something else acute. And then any signs clinically or on imaging that suggest chronic retention, the bladder not emptying properly over time, leading to what we call an overflow bladder, those need immediate specialist attention.
That's a critical distinction. Okay, let's shift to assessment then. You mentioned patients often come in worried about prostate cancer. So how do clinicians get past those assumptions, manage that anxiety, and actually figure out what's going on?
Well, the first step is always a really thorough history, the anamnesis. And like you said, handling that conversation sensitively, addressing the cancer fear directly is vital.
Building trust.
Exactly. Then we need objective data, because honestly, just asking patients about frequency or volume, their recall isn't always that accurate.
Right. So what tools give you that hard data? I think there are two main ones mentioned.
Yeah, we lean heavily on structured tools. First is the IPSS, the International Prostate Symptom Score. It's a questionnaire, 7 items.
Okay.
It scores symptoms from mild, like 1 to 7 points, up to severe, which is 20 to 35. It gives a great snapshot of how bad the symptoms are and how much they're impacting quality of life.
But, and this seems important for anyone listening, the IPS tells you how bad it feels, but not why, right?
Yeah.
It doesn't pinpoint the organ or the cause.
Exactly. It measures severity, not etiology. That's where the second tool comes in, the voiding diary, or Plastic book.
The diary. Tell us about that.
This is so essential. We ask the patient to keep it for, say, 1 to 3 days, record when they go, how much they void each time.
Why? Why not just ask them?
Because, as we said, a recall is unreliable. People often overestimate frequency or underestimate it. The diary gives us objective numbers: day frequency, night frequency, and crucially, the functional bladder capacity, the largest amount they voided in one go.
And that tells you what?
It helps identify patterns, like are they producing way too much urine overnight? That's nocturnal polyuria. Knowing that completely changes how you might advise them on treatment.
Got it. The diary seems like the hidden gem here. Now, thinking about efficiency, avoiding unnecessary tests and anxiety, what are the things the guidelines specifically say not to do routinely for these aspecific LUTS cases?
Okay, this is a really practical point. We should not routinely order a PSA test, prostate-specific antigen.
Really? But isn't that the prostate cancer test?
It's primarily used for cancer screening, yes. But for managing typical LUTS, the PSA level just doesn't reliably predict how bad the symptoms are or change the initial non-surgical treatment plan.
So chasing a slightly high PSA in someone with, say, just frequency might just cause needless worry.
Exactly. Needless anxiety, potentially more tests that aren't indicated for the LUTS itself.
Okay, so no routine PSA. What else?
Routine kidney function tests, creatinine, eGFR, aren't needed unless there are specific red flags suggesting kidney issues.
Makes sense.
And finally, routine ultrasound, just to measure the prostate volume. Also generally not recommended as a first step.
Because we keep coming back to this.
Because, again, prostate size often doesn't correlate well with the symptoms or dictate the first-line treatment for aspecific LUTS. We need to focus on how things are functioning, not just how big the gland is.
Function over form, in a way. Okay. That focus leads us right into treatment. And the guidance seems crystal clear. Medication effects are often, quote, very limited. So the priority is non-medication advice first.
Absolutely the cornerstone. We start with behavior, with lifestyle. Simple changes often work best because they target those systemic multifactorial roots we talked about.
Like what specific?
Things like managing constipation straining can affect pelvic nerves. Getting regular physical activity. There's some evidence it might protect against symptoms getting worse over time.
Okay. What about the fluids advice? Drink less, especially at night.
Well, that has to be targeted. If the voiding diary confirms they're making too much urine at night, nocturnal polyuria, then reducing fluids, especially in the evening, makes sense. It's evidence-based then.
Not just a blanket drink less.
Right. And for stimulants like coffee and alcohol, the hard evidence linking cutting back to major symptom improvement is actually a bit limited, surprisingly.
Oh.
But a trial reduction is still often advised. It's low risk, easy to try, see if it makes a difference for that individual.
Makes sense. What about techniques for specific symptoms, like that awful urgency feeling?
Yeah, for urgency and frequency, the go-to non-medication approach is bladder training combined with pelvic floor exercises, PFE.
Pelvic floor exercises. Kegels.
Essentially, yes. Strengthening those muscles. Behavioral treatment, which bundles bladder training, urge suppression techniques, timed voiding, and PFE is often preferred over jumping straight to medication. It gives the patient control.
Now, I noticed the sources say the studies on PFE effectiveness are sometimes a bit mixed, maybe low quality. So why are they still recommended so strongly as a first step? Is it just because they can't hurt?
That's a fair question about the evidence level. They remain fundamental partly because they are non-invasive, no side effects, and importantly, self-management programs that include PFE have been shown to reduce overall symptom severity.
So the package works, even if isolating the PFE effect is tricky.
Pretty much. Given the potential upside and zero downside, it's a very logical place to start before considering drugs.
Okay, sensible. Right, let's talk about the drugs then. Reserved for more severe symptoms when the behavioral stuff hasn't quite cut it. But we have to repeat, the effects are often modest.
Modest, yes. But for some patients, they provide necessary relief. The key is, the choice of drug depends entirely on the main symptom. Is it mostly flow problems like obstruction? Or is it storage problems like urgency?
So category 1, aspecific or obstructive complaints, that hesitancy, weak stream stuff. What's the first line drug?
Alpha blockers. Drugs like tamsulosin or alfusen.
Why start there?
They work by relaxing the smooth muscle tissue in the prostate itself and at the bladder neck. This reduces the resistance to flow. Generally, they give the biggest symptom improvement compared to other drug classes for these types of symptoms.
And side effects?
Usually pretty manageable, maybe some dizziness, sometimes changes in ejaculation, generally well tolerated.
Okay, now what about PDE5 inhibitors? Like tadalafil, the erectile dysfunction drugs?
Yeah.
They get a mention, but they're pricey. Why are they even in the guideline for LUTS?
Good point. They are only really considered if the patient also has erectile dysfunction and wants treatment for both things at the same time.
So it's a 2-for-1 situation, potentially.
Potentially. But if the goal is just LUTS relief, especially flow symptoms, the evidence doesn't really show they're better than alpha blockers, and they cost a lot more. So alpha blockers remain the preferred first choice for LUTS alone.
Got it. Okay, let's switch gears to the storage issues, urgency, frequency, maybe some incontinence, overactive bladder syndrome territory.
Right. If bladder training hasn't worked sufficiently, then we consider muscarine antagonists, drugs like sulfonecin or tolterodine.
And what do they target mainly?
Their main benefit seems to be reducing episodes of incontinence, which can be huge for quality of life.
Yeah.
They tend to have less effect on just frequency alone, though.
Now, there's a big warning with these, especially for older guys, right?
Yes, a crucial caution. We worry about anticholinergic side effects.
Can you break that down simply?
Sure. These drugs block a chemical messenger called acetylcholine. Acetylcholine is important for muscle control, but also for brain function memory cognition. So blocking it can sometimes cause side effects beyond the bladder, especially in older, more vulnerable patients. Things like confusion, even delirium. It's a real risk we have to weigh carefully.
So if those aren't suitable because of the risk?
Then the next option is mirabegron. It's a beta-3 agonist, works differently. But it's reserved for when the antagonists aren't appropriate or don't work, partly because the cost is significantly higher.
Right. Finally, let's talk about nocturia. Waking up at night to pee. Huge quality of life issue. What can meds do?
Okay, here's the slightly disappointing reality. The effect of any medication on purely nocturnal frequency is honestly extremely small, often not even clinically meaningful.
Really? Not much help from pills for that?
Generally, no. Muscarine antagonists or alpha blockers might be considered, but only if the nocturia is happening alongside those other OAB or obstructive symptoms they treat.
So you treat the main problem, hope the nocturia improves a bit as a side effect.
Kind of, yeah. But we specifically advise against using several drugs just for nocturia. Desmopressin is one. It can cause low sodium levels, especially in older adults, risk of hyponatremia.
Okay, dangerous.
And loop diuretics, certain hormone blockers like 5-alpha reductase inhibitors, even PDE5 inhibitors, none are generally recommended just to treat nocturia.
So for most men bothered primarily by getting up at night, it comes back to non-medication. Back to that voiding diary.
Exactly. Look at the diary. Is it nocturnal polyuria? Then targeted evening fluid restriction is likely the best bet. It's about behavioral changes based on objective evidence.
Wow, this has been incredibly detailed, a real roadmap. Let's try and synthesize the main message for everyone listening.
Okay. I think the primary thing is male LUTS is common, it's complex, and for the vast majority, it's not just about the prostate getting bigger, it's multifactorial.
Right.
So relief usually starts with the simple, low-risk things, lifestyle changes, behavioral training like bladder training or PFE.
If those don't cut it.
Then yes, medication has a role, but it has to be tailored. Alpha blockers are the starting point for flow problems, muscarine antagonists maybe for urgency incontinence, but always aligning with the patient's main symptom and their overall health.
And maybe a final thought to leave people with, connecting back to that multifactorial idea. We know LUTS often travels with things like high blood pressure, diabetes, maybe neurological changes. Consider men who end up in acute urinary retention, suddenly can't pee at all.
Yeah.
Even when doctors use alpha blockers, strong drugs, to help get the catheter out successfully. The chance of it happening again, the relapse rate, it's still quite high.
It is surprisingly high, yes.
So what does that high recurrence rate tell you about the real power of those underlying systemic issues? Does it suggest that maybe long-term focusing just on clearing the pipe isn't enough? Should we perhaps be thinking more aggressively about managing the blood pressure, the diabetes, the nerve health? Because those might be the true drivers that keep causing the problem.
That's a fascinating point. The blockage might be the immediate crisis, but the underlying systemic dysregulation, that might be the thing that needs deeper, ongoing management. Definitely something to think about as you apply this knowledge.
Indeed, something to mull over. Until next time, keep digging deeper.